Case. An older man presented for acute care. He was hemodynamically stable, and this was the rhythm seen on a long lead 2 rhythm strip. This rhythm was diagnosed as atrial flutter. Do you agree with this rhythm diagnosis? In answering, I'll go one step further by asking, why is this rhythm unlikely to be a flutter? Hint, do you see an underlying rhythm? What's in the red circle? Do you see similar deflections elsewhere on the tracing? What are the red arrows pointing to? Your attention was probably drawn to the smaller deflections highlighted by the thin red vertical lines. This is artifact. It's not a flutter. With typical atrial flutter, there is a near-perfect sawtooth pattern where each tooth in the saw is regular and occurs at a rate that is very close to 300 per minute, or approximately 1 flutter wave occurring with each large box on ECG grid paper. This is not what we see here, where the deflections under the thin red lines are of small amplitude, irregular, and occur at a rate much faster than 300 per minute. The best way to prove artifact is when you can identify an underlying rhythm that is undisturbed by the deflections you see, as is the case here for the red arrows highlighting sinus P waves. Finally, when all else fails, look at the patient, whose hand was trembling with an obvious Parkinsonian tremor. This raises the question of whether the patient you are seeing does or does not have an arrhythmia. What then are the symptoms that patients with arrhythmias are likely to have? Most of these are obvious as listed here. I'll just briefly comment on chest pain, in that occasionally our service would have patients referred to us with the diagnosis of chest pain, rule out MI, when in fact the problem was a supraventricular tachycardia. Once treated with conversion to sinus rhythm, the symptom of chest pain disappeared. So it's good to be aware of the variety of ways in which patients with arrhythmias may present. And then there is this, the patient with an arrhythmia who has no symptoms at all, which raises the question of how badly you want to know if the patient you are seeing does or does not have an arrhythmia. We know from monitoring studies that more than half of all young adults have at least some PVCs on 24-hour monitoring. The percentage of people with arrhythmias goes up with age, so that more than half of you viewing this video probably have some arrhythmias that you may or may not be aware of, which leads me to one of my favorite quotes. A clinician deserves the results of the lab tests that he or she decides to order. There are many patients for whom the clinician might prefer not to know if the patient in front of them has an arrhythmia. That said, there are times when we do want to know. So how can we tell if the patient has an arrhythmia? Obviously, by doing an ECG. But it's not always so easy if the patient is not having their arrhythmia at the time you are seeing them. Which leads to the subject of Holter monitoring. The first Holter device was developed by Jeff Holter in 1947. It weighed 84 pounds. Back in those days, you got a 2-for-1 in that in addition to a Holter, your patient got a stress test carrying the device around for 24 hours. There has been much evolution since then. Holter devices are now significantly smaller, although many are still cumbersome with a series of wires. But the evolution continues, as shown by the recently developed Band-Aid-sized Zeo patch that can be worn for up to 2 weeks at a time without being overly bothersome to the patient. One of the main drawbacks of Holter monitoring had been limitation to a 24-hour monitoring period, which was problematic if arrhythmias were infrequent. For example, a patient might have a sustained run of ventricular tachycardia only occur every week or two, which might be totally missed if monitoring was limited to 24 hours. This is the key question. Are symptoms related to arrhythmias that the patient is having? We know symptoms are common. And we know arrhythmias are common. The key is to determine if the two are related in any given patient. The best way to correlate symptoms and arrhythmias is to have the patient fill out a diary. For example, here is a diary filled out by a patient during their 24-hour period of monitoring. Although not in English, you get the idea. Lots of activities with the specific time of occurrence are noted. Or should I say, this is only the first page of this patient's diary. I stopped at page 4, but the point is made how a diary such as this might lead us to question if an arrhythmia is the primary diagnosis. That said, this was my clinical reality. More than half of all the diaries I'd get back for the Holters I interpreted for 35 clinicians in our primary care clinic looked like this, blank. There's just no way to correlate symptoms with arrhythmias when the diary is blank. Event monitors. In recent years, there has been a tendency favoring event monitors, in which the patient presses a button to begin recording the moment that symptoms are experienced. While this reduces some of the dependence on the patient's diary, the challenge to us remains to try and correlate symptoms with arrhythmias. Which leads me to the future of ECG monitoring. And even though Stardate 41254.7 takes us to the 24th century, the idea for this monitoring device was conceived of by Gene Roddenberry, the genius creator of the Star Trek series way back in 1964. It's the medical tricoder. You probably recall the Chief Medical Officer Bones and then Dr. Beverly Crusher using the device on patients treated on the U.S. Enterprise. Here's Dr. Crusher examining Counselor Troy with the tricoder. And within the space of a few seconds, she has her diagnosis. Flashback to the present. How many of you viewers are familiar with AliveCor on iPhone? Here's the medical tricoder, and here's the iPhone. Similar basic principle, similar handheld size for the device. The headline says, AliveCor iPhone ECG transforms heart rhythm monitoring, which it has been doing since AliveCor first came out circa 2012. So the future of ECG monitoring is now. I priced this over-the-counter FDA-cleared iPhone monitor on Amazon.com in September 2014, and it is now marked at a price of $129. I have no personal financial interest in the device. I only want to convey that purchase by consumers is now readily affordable. AliveCor uses Bluetooth technology and attaches to an iPhone. The patient can view their own recording in the privacy of their home or in the doctor's office in real time. Here you see the electrodes attaching to the back of an iPhone. Touching the electrodes with the fingers of the left and right hand produces a true-time recording comparable to standard lead 1. The device stores data, which can be viewed at the patient's next visit or even emailed to the treating physician. Here's what the recording looks like. Admittedly, there's some artifact. You can filter out some of this artifact either by stabilizing the iPhone in your lap or by recording directly from the chest. Note how clear and free of artifact this recording has become. Now, whether you, as the patient's primary care provider, want all of their rhythms emailed to you is another question, but the potential for correlating rhythms with symptoms is higher than ever before. The future of ECG monitoring truly is now. So your next patient walks into the room and tells you, I have palpitations. In addressing this very common patient concern, I like to refer to a study by Weber and Kapoor in which they looked at some 200 patients who presented to a primary care or emergency setting with palpitations as the chief complaint. The findings of their study revealed that two main causes accounted for the reason for palpitations in over 80% of the patients. Obviously, an arrhythmia was one of the causes. Can you guess the other main cause of palpitations? The answer relates to a psychological cause, either generalized anxiety or panic disorder. Realize that on occasion a patient may have both, so that just because the patient has panic doesn't mean that they might not also have an arrhythmia. But it's helpful to know that up to half of all patients who come to the doctor because of palpitations have an anxiety disorder instead of an arrhythmia. Which arrhythmia was most likely to cause palpitations? It's of interest that any arrhythmia could be the culprit. So not only VTach or atrial fibrillation, but also premature beats, even if infrequent, or simple bradycardia might be equally likely to result in the subjective symptom of palpitations. The good news, in the study of 200 patients presenting with palpitations as the chief complaint, was that in general, the long-term prognosis was benign when palpitations was the reason these patients sought care. The less good news can be summarized by the famous line from the movie, The Terminator, "I'll be back." There is an extremely high rate of recurrence for these patients who seek care because they are having palpitations. The large majority do not have a serious cardiac disorder, but you are likely to see them in your office more than once for this complaint. Pearl. One of the most helpful findings that I derived from this study was that in patients who present with palpitations, there are a few clues that may make it more or less likely that palpitations are due to an arrhythmia. An arrhythmia is more likely if the patient has underlying heart disease, if the palpitations are perceived by the patient as irregular, that is, the patient may be able to describe or tap out an irregular cadence for their heartbeat, and finally, if palpitations last more than 5 minutes. I especially like this last clue. Very often, when you ask the patient how long their palpitations last, they'll say just a few seconds. Once you hear that, it becomes far less likely that their symptoms are due to an arrhythmia, whereas longer-lasting symptoms are clearly of more concern. All of which leaves us with the question of whether iPhone monitoring will simplify diagnosis of the patient with symptoms that we've never been able to correlate with ECG abnormalities. Next case. A 50 to 60-ish-year-old woman wanted my opinion. She was told that she had an arrhythmia. So she turned to me and asked, "What do I think?" How would you respond? Imagine this patient was seeing you in your office. She was otherwise healthy, not on any cardioactive medications, and she had no significant medical problems. She tells you that she had already been referred to a cardiologist in town who told her she could either do nothing or take a daily beta blocker. What are you thinking? Which arrhythmias would you think might be most likely in this case? And what additional historical information would you want to know? Now, clearly, this case could be anything, but given that the patient is a 50 to 60-ish-year-old woman with some type of arrhythmia, but on no medications and with no significant medical history, who had already been seen by a cardiologist who said she could either do nothing or take a daily beta blocker, she probably has something benign. It would seem unlikely that she has atrial fibrillation because there was no mention of any discussion involving anticoagulation. So she could be having early beats like PACs or PVCs, or she could even have some type of reentry tachycardia such as PSVT. But whatever it is, her arrhythmia is probably benign. Let's consider again what the cardiologist told this patient, namely that she could either do nothing or take a daily beta blocker. What third management option did the cardiologist forget to mention? Does this patient need to take the beta blocker every day? Remember, she probably has something benign for which a cardiologist thought one appropriate therapeutic option would be to do nothing at all, which raises the concept of suggesting the option of intermittent therapy to selected appropriate patients. Let them take a medication such as a beta blocker or diltiazem or verapamil when they are having symptoms. They'll use a lot less medication with this strategy. It will be cheaper, the chance of side effects is much less, and patients love this option because it restores some sense of control for their own health care. I like to illustrate this concept by anecdote of a patient I cared for over a course of many years. She was a 30-ish-year-old woman with a benign arrhythmia. When stressed, as she was for a couple of months each year, she took her medication daily. But when her situational stress was under better control, as it was for most of the year, she only took her medication PRN when she had symptoms. Pearl. A beta blocker will be the most commonly used agent for such benign arrhythmias. Many patients surprisingly get good therapeutic response from an extremely low dose of a beta blocker. That may be all that is needed to attenuate sympathetic tone enough to control the arrhythmia. Therefore, be sure to try low doses of a beta blocker first when using this class of agent to treat a benign arrhythmia. An essential question to address regarding practical clinical management of cardiac arrhythmias in a primary care setting is whether we need to know precisely what the rhythm is before we begin our treatment. Fortunately, the answer is no, just like it is for so many other clinical problems in primary care. We do need to know if the rhythm is likely to be benign, but we don't necessarily need to know exactly what the rhythm is. One key to determining if the rhythm is benign is to assess the patient for underlying heart disease. Most of the time, if there is no underlying heart disease, the rhythm is far less worrisome. Assessing the likelihood of underlying heart disease can usually be done quite quickly by a few simple steps. If the history is unremarkable, cardiac risk factors are minimal, cardiovascular exam is normal, and if there is no significant abnormality on baseline ECG, then underlying heart disease becomes far less likely. If concerned about underlying structural heart disease, you can always order an echo, but I'll emphasize that often an echo will not be needed. And on occasion, when concerned about underlying coronary disease, some type of stress test might be needed, but most patients with benign-sounding arrhythmias do not need a stress test. We are looking for red flags, especially for the younger patient with an arrhythmia or the young to early middle-aged adult. Is there a positive history of unexplained sudden death at an early age in the immediate family? One of the biggest red flags is if the patient conveys a history of syncope or presyncope during activity that sounds like it might be due to an arrhythmia. As a primary care clinician, we are trying to determine when to refer to the cardiologist, or more specifically to the electrophysiologist, as the EP cardiologist is the true expert in arrhythmia evaluation and management. We refer when there are red flags. The biggest red flag is exertional syncope. Other reasons for referral are that your management isn't controlling your patient's symptoms. Note that I list WPW as a separate entity, to which I've added a question mark. It's helpful to be aware of the clinical reality that if WPW goes undetected until after age 40, that the patient is much less likely to get into trouble later on. So your 60 or 70-year-old patient who has never had symptoms, on who you incidentally discover on routine ECG that the patient has WPW, does not need to be referred unless they later develop symptomatic arrhythmias. This is very different than discovery of WPW in a pediatric patient, for whom you may want to refer to pediatric cardiology right away for evaluation by a specialist in that area. Ablation of the accessory pathway may cure the patient of WPW-related arrhythmias. At what point to refer the young to middle-aged adult with asymptomatic WPW is less well defined. Finally, refer your patient with arrhythmias when you, as a primary care clinician, are no longer comfortable managing the case. bottom line, and the key clinical message for primary care clinicians, you don't necessarily need to know what the rhythm is before starting treatment, as long as you are comfortable that the rhythm is likely to be benign, and comfortable with your own threshold for when to refer to cardiology. Next case. This is what you hear on exam. Note the irregularity. This is atrial fibrillation. There are many arrhythmias that we can comfortably identify simply by listening with a stethoscope. I always like to ask the patient while listening to their chest if they are aware of any irregularities or any skip beats. I don't let on whether I am or am not hearing any irregularities because I want to know if this particular patient is or is not aware of any irregularities in their heart rhythm that may be occurring. If I hear skips but the patient doesn't feel anything, this is important information regarding the patient's lack of awareness as to when they are having an arrhythmia. On the other hand, if each time I hear an early beat, the patient nods their head, then I've discovered the optimal cost-efficient monitoring method for this particular patient. Now listen again. What are you hearing? What rhythm is this consistent with? Note the underlying regularity, that is sinus rhythm, which is frequently interrupted by early beats, which I'll call ectopics. Does it matter if these early beats are premature atrial contractions, premature junctional contractions, or premature ventricular contractions? The clinical point to emphasize is that for practical purposes, initial management of the patient with premature beats will be the same regardless of whether we are hearing PACs, PJCs, or PVCs, provided there are no long runs of sustained arrhythmia. Of note, we can distinguish between these three types of early beats on ECG. PACs and PJCs occur early and most often manifest a normal width QRS that is similar or identical in morphology to normal sinus beats. These beats are often preceded by a premature P wave. In contrast, PVCs are wide and not preceded by any premature P wave. But regardless of whether the patient in front of you is having PACs, PJCs, or PVCs, initial practical management steps are the same. Assess for the likelihood of underlying heart disease. Premature beats occurring in a patient with ischemia or heart failure will often go away if ischemia or heart failure are treated. If, on the other hand, the patient with premature beats does not have any underlying heart disease, then it becomes much more likely that their arrhythmia is benign. Look for anything else you might be able to fix or address, such as hypoxemia, electrolyte disorder, or psychological stress. Inquire about any substances that might be causing or exacerbating the arrhythmia. Caffeine is an especially likely culprit, even in small amounts in susceptible individuals, but also alcohol and other over-the-counter sympathomimetics. Does the patient get better when you address these issues? If so, that may be all you need to do for a benign arrhythmia. For selected patients with especially bothersome symptoms, a trial of medication, perhaps a low-dose intermittent beta blocker, may be in order. As always in primary care, individualize your management to the patient in front of you. We've reached the end of part 1 of this video on a practical approach to cardiac arrhythmias in primary care. In this first part, we've laid the foundation, beginning with the fundamental question of ensuring that the rhythm is real and not artifact. We've discussed monitoring methods and have emphasized the importance of the clinical scenario for determining how to proceed. A key issue from a primary care perspective is determining if the rhythm is likely to be benign or if there are red flags that signal a need for referral. My goal for the next part of this video is to apply these foundation principles with a concise clinical overview on management of the most common arrhythmias you are likely to see in primary care.